Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 425 of our pharmacotherapy series, which majors in adverse effects of chemotherapy and targeted agents. This video is a continuation of the case of patient CLW who was discussed in part 424 of this pharmacotherapy series. CLW recently completed her course of total breast radiation therapy. She plans to leave for a 1-week vacation in Florida 3 days after this clinic visit. My questions to you read: are there any interactions between radiation therapy and sunlight exposure with cytotoxic anti-cancer agents? Are there any specific precautions CLW should take, or signs and symptoms of toxicity that she should know about? The interactions between cytotoxic therapy and radiation therapy or ultraviolet light, from both external beam and natural sources, can be divided into radiation sensitization, radiation recall, photosensitivity reactions, and sunburn reactivation. Several excellent reviews are available that describe each of these interactions in detail. A discussion of the important principles of the interaction between radiation therapy and cytotoxic therapy follows. A synergistic interaction between a small number of cytotoxic agents and radiation therapy results in an enhanced radiation effect. This may be caused by an agent's ability to interfere with radiation repair. Radiation therapy can alter the molecular structure of DNA, but excision repair allows cells to remove small, damaged portions of one strand of DNA and insert new bases using the other strand as a template. This repair mechanism requires several enzymes, including DNA polymerase. Cytotoxic therapy agents can interfere with some of the enzymes and synthetic mechanisms needed to repair damaged cells. Although the synergistic effects of radiation therapy and cytotoxic therapy are often exploited therapeutically for the treatment of solid tumors, these reactions can inadvertently cause undesirable reactions in non-tumor tissues, such as the skin, esophagus, lung, and gastrointestinal tract. The skin is the most common target of radiation reactions. These reactions can produce severe tissue necrosis, which can compromise organ function and delay or mandate discontinuation of future treatment courses. These reactions may be further classified as either radiation sensitivity or radiation recall reactions. The primary distinction between radiation sensitivity reactions and radiation recall reactions lies in the temporal relationship between radiation therapy and chemotherapy. Generally, sensitivity reactions occur when chemotherapy is given concurrently or within 1 week of radiation therapy. In comparison, recall reactions occur several weeks to years after radiation therapy, when the administration of chemotherapy induces an inflammatory reaction in tissues previously treated with radiation. Radiation recall is independent of previous, clinically apparent radiation damage. Not surprisingly, the chemotherapy agents that have been associated with radiation recall reactions are the same as those that cause radiation sensitivity reactions. Management of reactions is supportive and consists primarily of topical agents including corticosteroids. Because UV light has sufficient energy to cause photochemical changes in biologic molecules, cytotoxic agents can interact with it. The subsequent reactions are usually less severe than reactions that occur with radiation therapy, and they may be caused by a different mechanism. Photosensitivity reactions, defined as enhanced erythema responses to UV light, have been reported with specific agents. Methotrexate can also reactivate sunburns, causing a similar, but less severe reaction compared with the radiation recall reactions described previously. The reaction can be more severe than the initial sunburn, resulting in severe blisters, and it usually occurs only in patients who receive large doses of methotrexate. Although the precise incidences of photosensitivity reactions caused by chemotherapy agents are unknown, they may be more common than generally believed. For example, photosensitivity may account for many of the erythematous periodic rashes attributed to allergy. CLW received doxorubicin, which can interact with radiation therapy. Although not commonly reported, doxorubicin also can cause some increased erythema in the specific area of skin treated with radiation. Because CLW may have an increased risk for a photosensitivity reaction, she should be advised to avoid direct exposure to the sunlight for several days to a week after chemotherapy. Although no data exist regarding the efficacy of sunscreens in this patient population, CLW should be advised to use a protective sunscreen with a high sun protective factor when she cannot avoid sun exposure. Protective clothing and a hat can provide additional protection for CLW. Furthermore, she should periodically assess her skin's reaction to the sun with intermittent periods of rest and observation throughout the day. My next questions to you read: how will CLW know whether she has a radiation reaction? How should she be treated if such a reaction occurs? If CLW has a radiation reaction, she will experience easy burning and erythema or redness, followed by dry desquamation. With a more severe reaction, small blisters, that is vesicles, and oozing can develop. Necrosis with persistent painful ulceration can also occur in severe cases. Post-inflammatory hyperpigmentation or depigmentation may follow. Treatment options vary, depending on reaction severity. Milder cases can be treated with topical steroids in an emollient cream base and cool wet compresses. Necrosis and ulcers are notoriously difficult to treat, however, because radiated skin does not heal well. Ulcers are often treated with surgical debridement to keep the ulcer clean. Even when the ulcers are clean, exudation and bacterial contamination can be persistent. Radiation reactions that occur in tissues other than the skin, e.g., the lungs, esophagus, gastrointestinal tract, often are treated with oral corticosteroids, although data regarding the efficacy of these agents in ameliorating the symptoms or reducing the extent of damage are lacking. If CLW experiences any of these signs or symptoms, she should immediately seek medical attention. The next question reads, CLW complained of pain and burning at the injection site immediately after the administration of her third course of IV chemotherapy with doxorubicin and cyclophosphamide. She described the sensation as being distinctly different from the mild discomfort she had experienced with previous courses. Physical examination of the injection site revealed mild erythema and slight induration. So my question to you is, what types of local reactions can occur after the administration of chemotherapy? Several distinct types of local reactions, ranging from transient local irritation to severe tissue necrosis of the skin, surrounding vasculature, and supporting structures, have been reported after cytotoxic chemotherapy. Some reactions are characterized by immediate local burning, itching, and erythema. Some patients may also experience flare reaction along the length of the vein used for treatment. More severe reactions, including irritation of the vein, or phlebitis, caused by the irritant properties of an agent or a diluent, and possibly extravasation, can occur after cytotoxic chemotherapy. Extravasation, a potentially serious local reaction, is seen in approximately 1% of chemotherapy administration and occurs when IV medications are accidentally administered into the surrounding tissue, either by leakage or by a needle puncturing the vein, causing direct exposure and damage to surrounding tissues. Reactions resulting from the extravasation of agents with vesicant or irritant properties are more severe. All agents with vesicant properties potentially can produce devastating reactions. Agents known to bind to DNA, i.e., the anthracyclines, have the propensity to produce the most severe damage. Treatment with a cytotoxic agent with these properties can produce phlebitis and pain. However, extravasations can cause severe local irritation or soft tissue ulcers, depending on the agent and the amount and concentration of the extravasated drug. In addition, no clear agreement exists regarding the vesicant potential of many cytotoxic chemotherapy agents, and various references may categorize agents differently based on their vesicant or irritant properties. Initially, it may be impossible to distinguish a local irritant reaction from a vesicant extravasation. Therefore, if an agent with vesicant or irritant properties has been administered, the reaction should be treated as a potential extravasation. Patients who experience an extravasation can show a range of different signs or symptoms. Infiltration of a vesicant into tissue often produces a severe burning sensation that may persist for hours. In some cases, no immediate symptoms or signs are evident. However, in the days to weeks that follow, the skin overlying the extravasation site may become reddened and firm. The redness may gradually diminish or progress to ulceration and necrosis. My next question to you reads, what factors in CLW increase her risk of extravasation, and what administration techniques and precautions can minimize these risks? Several factors have been associated with an increased risk of extravasation and subsequent tissue damage after administration of cytotoxic chemotherapy. Risk factors include generalized vascular disease, commonly found in elderly and debilitated patients or in patients who have undergone frequent venipuncture and treatment with irritating chemotherapy. The latter causes venous fragility and instability or decreased local blood flow. Elevated venous pressure, which typically occurs in patients with an obstructed superior vena cava or venous drainage after axillary dissection, prior radiation therapy to the injection site, recent venipuncture in the same vein, use of injection sites over joints, which increases the risk of needle dislodgement, and others. Tissue damage may be more severe if extravasation occurs in areas with only a small amount of subcutaneous tissue, e.g., the back of the hand or wrist, because wound healing is more difficult and exposure of deeper structures, such as the tendons, is increased. These risks have led to the increased use of central catheters in patients receiving vesicant chemotherapy. L.W. has several risks for extravasation. She had an axillary lymph node dissection for her breast cancer, which places her at higher risk for obstructed venous drainage. Additionally, she has had multiple venous punctures, and she is a thin woman with relatively small amounts of subcutaneous tissue. Extravasations of agents with vesicant properties can produce devastating tissue damage that can potentially cause loss of an extremity or death. To prevent significant morbidity or mortality, major emphasis must be placed on prevention. All caretakers who administer agents with vesicant or irritant properties should be skilled in IV drug administration and receive special instruction before administering these agents. The patient also must be told how agent administration should feel and to report immediately any change in sensation, including pain, burning, or itching. The next question reads, CLW's oncology nurse believes that the doxorubicin may have extravasated during administration. So my questions to you are, how should this be managed? Do management strategies differ for other vesicant agents? Immediate management of a potential vesicant extravasation should include stopping the injection if the entire agent has not been administered. Various other recommended measures may minimize vesicant exposure and subsequent tissue damage. These include application of cold compresses to the extravasation site and elevation of the extremity. Cold compresses have been shown to cause vasoconstriction, which can help to localize the extravasation and allow time for local vessels to displace the extravasated agent, whereas warm compresses are thought to induce vasodilation, increase drug distribution and absorption, therefore decreasing the concentration of the offending agent around the immediate site. Warm compresses are recommended for vinca alkaloids and epipodophyllotoxins. With the exception of these two classes of agents, cooling has been shown to be more effective than warm compresses. Specific antidotes thought to inactivate the extravasated chemotherapy have been suggested. However, many of these antidotes are based on observations in a few patients or animal models, and their effectiveness, in many cases, is unsubstantiated. Antidotes recommended in some guidelines may actually worsen tissue damage, e.g., sodium bicarbonate for doxorubicin. Dexrazoxane has been established as a reliable antidote for anthracycline extravasations. Dexrazoxane, an iron chelator, was studied based on evidence that it protects cardiac tissue from anthracycline-induced toxicities. 2 prospective, multi-center, single-arm trials were conducted in a total of 54 evaluable patients with anthracycline extravasations. In 98.2% of patients, surgical intervention was avoided and 71% of patients were able to continue treatment regimen without any delays. Hospitalization of 41% of patients was necessary secondary to their extravasation. Toxicities included myelosuppression, increased liver function tests, nausea, and pain at the dexrazoxane infusion site. Based on these results, dexrazoxane is approved for the treatment of anthracycline extravasations. Dexrazoxane is given once daily for 3 days at a dose of 1000 mg per meter squared IV on days 1 and 2, and 500 mg per meter squared IV on day 3. Administration should start within 6 hours of extravasation. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 426.